Okay, so the title of this is Understanding Responses to Trauma and Applying Trauma-Informed Care. And this is intended as a basic training. And the assumption is that even though I know that you know a lot, there's also an assumption that there might be somebody in the room that has not yet had a lot of information about trauma and PTSD and what that is. And I'm willing to answer any questions that anybody has along the way so that this can be personalized for you. So we already did this, but if you want to add anything else, what are you hoping to do or learn from this workshop, please do that. And I'm going to begin with some basic definitions. If a service provider is trauma uninformed, the question to a client or to somebody we are providing services and to support to is this question: what is wrong with you? And even if we don't say it out loud, we might think it in our mind. And in fact, when I first entered the field way back in the 80s, and I bet you some of you may not even have been born yet, but when I entered the field, this is how we were trained, is to find out what's wrong with people, what their deficits were, and try to fix those kinds of things. The idea of person-centered care, strength-based assessment, being trauma-informed, being recovery-focused, that wasn't even part of our vocabulary. Sadly, though, in 2021, I still hear this question a lot, that there's something wrong with the client. If the client would only do such and such, they wouldn't have any problems. So trauma uninformed asks the question, what is wrong with you? Trauma informed, however, flips the question to, what happened to you? This invites a larger conversation and does not assume that the person in front of us has any deficits or pathology. Instead, we're asking about what has happened. So, and then the last bullet on this is experiencing repeated or extreme exposure to aversive details of traumatic events. So that's what I went over the first workshop that I did and how this applies to us and the work that we do. So I'm not going to talk about that again, but just, for those of you who were not at the last workshop, that we can be impacted by the experiences of our clients. So being trauma-informed means that we need then a broader definition. And so this was the work of Dr. Kenneth Hardy that was already mentioned, that, trauma is something that devastates one's being. And at the same time, it overwhelms, destroys, or neutralizes coping. So what this is really saying is that this is something that is happening to someone. You will notice it doesn't say the person has developed maladaptive coping, that the person has made unhealthy choices. It doesn't say anything like that at all. And being trauma-informed means that we want to eliminate those words from our vocabulary. And instead, what Dr. Hardy is saying is that traumatic experiences are those that devastates the person. And the ACE study, the Adverse Childhood Experiences, which if we were going to rename that today, probably would be, traumatic childhood experiences, those things that that really impact, somebody's development, how they view the world. And then there are other things that, as after somebody has developed, they've made sense of the world, that is devastating to the person. This could happen in childhood, this could happen as an adult, it could happen both. But the idea is that it's something that overwhelms, destroys, or neutralizes coping. It doesn't have anything to do with making unhealthy choices or developing maladaptive coping mechanisms. So a simple example that I usually use at this point is probably 4 years ago now, we had a blizzard here in Connecticut. We had at least 3 feet of snow. And we know how to do snow in New England, right? We know how to prepare. We know how to handle it. We have the plow trucks, all of that stuff. But this event overwhelmed our usual capacity to cope and to plan. We had to get help from other states. We had to get equipment from other states. There was no place to put the snow. We had to get waivers to dump the snow into the waterways. We had to, schools were closed for an extended period of time. Power was out for an extended period of time. It doesn't have anything to do with our state not being able to manage and plan and cope with snow. We know how to do it, but it was the nature of the event, which is the next piece, that the nature of trauma is such that given enough trauma, anyone would experience difficulties as a result. So that's what, these are the definitions that we want to add to our, on our way to becoming trauma informed. So somebody unmuted themselves, I think. You have a question or a comment? Okay. So different types of trauma. And I began with the, what I consider accidental trauma, because I know that your work is focused on how people, helping people navigate following a natural disaster or pandemic or, some kind of disaster. So, these are the kinds of traumatic experiences that, it's not caused, it's not done on purpose. Harm is not done on purpose to another person generally. Obviously, there's some exceptions, but things that happen, as part of life, like natural disasters. However, just because these are, accidental, um, uh, kinds of trauma does not mean that somebody is not as impacted as with other kinds of trauma. And it's important to remember that, because often people say, oh, well, you're lucky it wasn't worse, or at least at least you're still alive, or at least this, or at least that. The minute we use the term at least, we have lost our empathy. So we want to pay attention to these kinds of experiences and people's lives, and how they can really impact individuals long term, individuals and communities long term. And some of this is also depends on how a community or a state or a country responds to these natural disasters. So we saw in Hurricane Katrina, what did we see? Primarily people of color, primarily people who are poor. And the national response was slow and embarrassing. Same thing in Puerto Rico, Hurricane Maria. So primarily people of color, and we have, a country that is slow to respond and critical of how the island or how the state responded, right? So critical of the people in charge and those kinds of things. So that then moves it into really a different kind of trauma, which is coming up in a minute. So we have accidental trauma. We have interpersonal trauma, which is what many of us think about when we think about trauma, things like domestic violence and assaults, rape, physical abuse, sexual abuse. So that's often the kind of trauma that we're thinking about first. And this is certainly a devastating aspect of traumatic experience, and it takes away the ability of a person to trust other people. And this is particularly damaging if it occurs over a long period of time or if it occurs in childhood. There's the witnessing trauma, so indirect trauma. So seeing that something is happening to other people or has happened to other people. For many years, I don't think it was until either 1985 or 1987 that the state of Connecticut admitted that children are impacted by what they see in the home. So if they see violence in the home, children are impacted by that. Prior to 1985 or 1987, the belief was, well, children are resilient. They don't really see things. They don't understand what they're seeing. They don't remember what they see. And we know that that is not true. Witnesses are often told things like, well, gee, aren't you lucky that it didn't happen to you? Or, aren't you lucky, grateful that it didn't happen to you? And all of this are not helpful things to say to people, that witnessing trauma can be very devastating and very impactful on the person. And then there's combat trauma, complicated by traumatic brain injury and military sexual trauma. And sociocultural trauma, which is, the types of traumatic experiences that are not part really of the DSM-5 definition and underlie a lot of the complex trauma, the daily experiences that people have. So racism, discrimination, homophobia, transphobia, oppression, poverty, terrorism. There's probably things that that I don't have here. But these are the kinds of experiences that are traumatic, that build up over time, and that often, and really until recently, these things have been talked about extensively for many, many, many years. However, it really isn't until recently that there's been a larger scale of listening and willing to talk about these types of traumatic experiences. So if you go back to the original definition that I gave this morning about being trauma-informed and cultural responsive, the question is, what has happened to you? What has happened to your people? And what is still happening right now? And that's the area that we really need to pay attention to. And there is actually a nice talk on sociocultural trauma that comes from the work of Dr. Kenneth Hardy. If anybody is interested in that, you can email me, and I'm happy to send you that link. I actually, when I do a full day of training, I show that talk in the training, but we don't have that time this morning. So any questions or comments?
I have a comment. Okay, so I have a comment. So listening to this information, and I've heard about PTSD and over the last years and things like that. Well, I think I tend to agree with my partner Germano on one thing that he said in terms of we live in the people we work with and the communities we actually live in have been exposed to every category you're saying in terms of, social racism, childhood trauma, sex, whatever. It's all there. For me, I can only speak for me, and doing this type of work as a crisis counselor for COVID is I find myself actually having to teach people that they've experienced trauma, because the way of life has always been, we've always heard gunshots. We always knew the secret when somebody was touching in the family and they shouldn't have. We've seen fires. We live in our own combat in our own poor communities. So you actually have to template it out and saying, yes, this is some type of trauma. So I find myself, in order to assist as well, is to educate folks that yes, you have been a victim of something terrible that has happened, and just basically raising the awareness of it for myself too, but it's an educating moment, and even to assist them that you can have this experience, and yes, we can still help you, even though you think that this is just something normal. Like teaching them that they are worthy of the services that we're offering them, and that although you think this is something normal or heightened, this is actually something real. So I don't know if I'm sounding right or, but I find it an educating moment of people even recognizing like the aha moment for them. Like, I've experienced trauma. And it's just, because they've lived with it so long. And even in this pandemic, helping them understand that.
Yeah. Yeah, thank you so much. I'm avoiding using people's names because I know my portion is being recorded. So just to let you know that I'm not ignoring your name, I'm just ignoring using names so that when the video person edits this, I don't have your names all over the place. But yes, you're absolutely on the right track with what it really means to be trauma informed, and that education piece is so important. And really, as crisis counselors, it's the most important piece. And one of the handouts that was sent to you includes an information sheet that you could give people. But you're right, that people think that what they've experienced is normal and everybody experiences it until you start talking about it and providing some education and asking of things about stress levels and explaining all of that, which I'm going to do. It's such an important piece, and if you're already doing that, so whoever is already doing that, that educational piece, that psychoeducational piece is one of the very first steps. It's part of psychological first aid, and it's part of the first stage of trauma recovery, is explaining what has happened to you. Again, not what's wrong with you, but explaining what has happened, and this is how you might be responding to it. So thank you very much for making that comment. Anybody else, questions or comments? So sociocultural trauma, and I made a note to myself so that I can send the Dr. Hardy video to everybody, or actually I'll ask somebody from the consortium to send it to everybody who's registered, because it's a worthwhile video for you to watch yourself or to share in a staff meeting if you have a cultural diversity committee. It would be an important video to watch. You can use it as a staff in-service training. It's an important piece. And if you've had training with me in, say, the last few years, I'm actually using a different video of a talk that Dr. Hardy gave just a few years ago. So there's a little update to that. Okay, so we have sociocultural trauma and then complex trauma, which was mentioned as, as compounded trauma or complex trauma. It's exposure to sustained, repeated, and multiple types of trauma, which I believe is the kind of traumatic experience that just about everybody that we work with has experienced. This is what their life has been like, is, the complex trauma. So sustained, repeated, and multiple types of trauma. And way back in 1992, there was a proposal that we need a different diagnosis for this and call this complex PTSD, that has never made it into the diagnostic and statistical manual. And so instead, people get diagnosed with other things like personality disorders or intermittent explosive disorders, or in children, conduct disorder. And so if we did have this diagnosis of complex PTSD, which there's been lots of research and publications on complex PTSD, but because it's not in the diagnostic and statistical manual, it's something like Santa Claus. It's something everybody believes in, but because it's not in the DSM, it doesn't exist. So we have complex trauma, and this is something really to keep in mind. you're working with people who are right now in an immediate crisis, but this is not the first thing that's ever happened to them. Okay, so now I want to talk a little bit about the aftermath of trauma, and this is also an important piece in terms of your educational toolbox. Something for you to understand and something for you to pass on to other people. And my experience has been that it's this piece of the education that is really very validating and very impactful on the person who has not understood what has happened to them and thinks that, like everybody else, thinks that there's something wrong with them rather than there's something that happened to them. So the aftermath of trauma, and I'm going to show a little video on this in a few minutes, but during times of normal stress, and I'm not suggesting that all of us, as we're living through this pandemic, that this is a time of normal stress, but if you can think before that, right? So during the times of normal stress, we do have that fight or flight response, right? So we have an area in our brain that serves as an alarm system. It's called the amygdala. So we have that alarm system that lets us know that there's a problem or there's something stressful happening, but we're still able to communicate with other areas in our brain, right? So that helps us make decision, stores information. So if your supervisor says to you, oh, that report that I thought was due tomorrow was really due today, you would have a little bit of that fight or flight response, but you'd still be able to access the part of your brain that would allow you to get the report done. If you're lost or you're stuck in traffic, you might have a little bit of that fight or flight response or freeze response, but you're still able to access the part of your brain that remembers, oh, gee, if I get off the next exit, I could take the back roads and I can still make it to work on time. So even during normal stress, we can feel a little bit of that fight or flight, but we still have access to the part of our brain, which is the front part of our brain that helps us make decisions and stores information, which is the hippocampus. And you don't need to remember any of these words, just need to know that during times of stress, we're still able to make decisions and access information. It might be a little harder. We might find that we have a hard time concentrating or that we're irritable, but we're still able to mostly figure things out. So that's during normal stress. And it looks like this, right? So we have, fight or flight or freeze, but we still have this problem-solving ability. During times of trauma, the alarm system in our brain becomes highly activated, and it's an automatic stress reaction. So people will, if you're driving down the highway or down a street, and all of a sudden somebody pulls out in front of you, your automatic reaction is to slam on the brakes, or maybe to put your arm out to protect the person that's sitting next to you. It's an automatic reaction. You didn't sit around evaluating the pros and cons of slamming on your brakes. It's an automatic response. So we have this automatic stress reaction that's really protective. And sometimes the automatic stress reaction looks like somebody slamming on the brakes, right? Or it can look like rage, or it can look like somebody is frozen, or submitting is sometimes another word, right? So frozen or playing dead, right? We see this in animals, but it's an automatic reaction, and it's something to protect us. That's the idea of this. It doesn't mean that there's something wrong with anybody. It's a protective mechanism that's part of our brain. It allows us to survive. And here's the problem, though. When the alarm system does not reset itself, that's when we're thinking about post-traumatic stress disorder, right? Something that that has a long-term effect. So how do you know when the alarm system does not reset itself? Well, my guess is since March, many of you have had, at least since March, if not before that, you might have a hard time with restful sleep. You might find that you're jumpy. You might find that you're more irritable than normal. You might find that, little things aggravate you more than normal. You also might find that you have some symptoms of depression. So you feel kind of stuck and you feel that you can't move. So this is how we know when the alarm system does not reset itself. Because during normal stress, once the problem is solved, once we get through the traffic or the report is due or whatever it is, we move into rest and digest. And by having us take a few deep breaths this morning before we got started, that's really what I was asking you to do. I was asking your stress response to settle down, right? So our stress response is the sympathetic nervous system, and I was asking your parasympathetic nervous system to come online. So rest and digest. So we have fight, flight, or freeze, and then we have rest and digest. So when the brain is not able to make that shift into rest and digest, it remains stuck. And this is what we see in complex PTSD, that just about everything is viewed as either a danger or a possible danger. And it could be something simple like somebody comes in to meet with you for your appointment or to have your telehealth visit or whatever it is, comes in to meet with you, or you're going to meet a client somewhere or whatever it is, and they show up and they're told, we're sorry, so-and-so went home sick, they can't meet with you today. And the person has a meltdown, right, in the waiting room or on the phone or whatever it is. Well, I knew that he never cared about me. I knew this place, doesn't help me. And it gets really angry or becomes really frozen and leaves, and then you never see the person again. So something that perhaps to most of us would be annoying, that we showed up for an appointment that was canceled, has really created this automatic stress reaction, right? So the brain is saying there's something really dangerous here because everything in your life has been dangerous. I am going to protect you. So the brain is not able really to tell the difference between what's safe and unsafe and views everything as threatening. So this is a key thing to remember. If you're working with somebody, providing crisis support for somebody that's not responsive to you, it could be that they're just numb and frozen, or that everything that you try to do, they tell you is not helpful. They don't like you, they don't like the agency, whatever it is, that it's really the brain that's moved into this protective mode. And when we say things like, you can trust me, we're here to help you, it doesn't make any sense to the brain that's in this highly activated state, right? Remember, the function of the brain is to protect us, and that's what they're going to do, right? That's what the brain is going to do, is be protective. And so it's going to view everything as unsafe, even what we might consider normal stressors. Everybody has the PowerPoint, and you could watch this on your own. It's an 8-minute video that explains what I just explained in terms of stress response. Just to and it's an animated film. And there's some parts that you may not be interested in, but there's a good section in the middle that talks about the brain and about the alarm system in the brain and how that really impacts somebody's ability to speak, to remember things, to link things together in a way that that's a coherent story. And often when people come into a treatment setting, they're accused of being liars and manipulators. So those are some words to eliminate from vocabulary in our quest to be trauma informed. When people are in this highly anxious state, it is hard for people to make sense of dates and times and how things fit together. And this is all a function of the brain. Remember, the brain is in a survival response mode, and it's really hard to connect to the other areas of the brain that make sense and order out of our memories and what it is that we've experienced. So even this morning, I mean, one of the reasons why I wanted to do some breathing with you is because I wanted to help myself focus. I was having a little bit of a hard time organizing myself to get started because I had technical problems. And I was so worried that I wasn't going to be able to get on and I wasn't going to be able to do this training. And I knew that there was over 30 people that was registered. So, even something like that can, even though I wasn't in survival response, I certainly was in a little bit of a stress response. So by doing that breathing, it's something that hopefully we all will do or learn to do with the people we're providing services to, but it's also helpful to us. Okay, so we have trauma in the brain, and here's the link to that video. And so this is what it looks like, right? Is that with traumatic stress, we have, the brain on high alarm. And so we have a brain that's really operating here in the fear circuitry, which in the early days of the DSM-5, before the DSM-5 was published, there was a discussion on renaming post-traumatic stress disorder as fear circuitry disorder because of the way the brain is reacting, as opposed to this, which is, this is the part of the brain. So this right here is how we make decisions, right? How we sort out long and short-term consequences. This part of the brain here is we draw on our past experiences to help us make decisions, right? So this is what's called the executive functioning. But when we have, somebody who's in crisis or has PTSD, right, we're looking at a brain that's really functioning right here in a very small area. And so what happens is a kitten looks like a tiger. So let's talk about some of the things that that you can do as you're supporting people in immediate crisis. So some basic elements of trauma-informed care. First are the principles of psychological first aid, which I think probably all or most of you might have already had some information. Maybe you've already had some training on this, but psychological first aid. So you think about first aid, what are we doing? We're helping somebody out until they can get medical care if they need medical care. But for psychological first aid, what is it? Somebody's in crisis. What is it that they need? Well, what do they need? They need reassurance, right? They need reassurance that you can help, that you'll be by their side, that you'll support them. That's really what people need. They don't need therapy, right? They just need reassurance. They need some information. So this was already mentioned. Teaching people about what's happened to them, what they might be experiencing. And you don't need to do that in the first 5 minutes after you meet somebody, because they might need other information, right? So they might need information on housing or food or other kinds of things. But we want to keep that in mind. What kind of information could be helpful to someone? Attending to safety and security, so the things that are mentioned, like food and housing, validating what somebody's experiencing. And by the way, don't validate in this way. Even though I have the term normalize here, don't say to somebody, oh, what you're experiencing is normal. Or don't use this phrase, you're experiencing a normal response to an abnormal event. Don't use that phrase. Both of them are overused. It becomes how it's experienced by the person is that they're just being dismissed. They're told that they're normal. You can certainly say to somebody, given everything that you've experienced, it's understandable, right? Or it makes sense to me what you're experiencing, rather than saying, oh, well, that's normal. It's very dismissive. And this is sometimes where good information can come in too, because you could say to somebody, well, sometimes when people experience and then fill in whatever the crisis is, they might be having a hard time sleeping, or they might be having, nightmares, or they may not feel like eating, or they might feel like they want to eat too much or something like that. So you're just giving a little bit of information that becomes validating for the person without saying to somebody, oh, well, that's normal. You want to encourage social supports and connection. One of the things that is so incredibly difficult during this pandemic has been getting social supports and connections, because we're all very limited on who we can see and when. There's a lot of this Zoom stuff going on, which can be really, really very helpful, but it's not exactly the same as seeing somebody in person. But whatever we can do to foster social supports. In fact, I just read an article in one of my counseling magazines that sometimes, as opposed to Zoom or what we're doing now, GoToMeeting, sometimes clients feel more connected just by talking on the phone, that they experience your voice differently. So that's something to keep in mind too, that maybe phone calls can be just as helpful as anything else. And then, as much as possible, encourage normal routine, which, there hasn't been anything normal really during this pandemic, but certainly as much as we can, making sure that, people are getting sleep if they can, and that they're eating, and, those kinds of basic things. But these are the principles of psychological first aid. You see that it doesn't say anything about talking about symptoms and diagnosing and therapies, and right, it's not talking about any of that. It's also not helpful to force or require details from people. They've experienced a crisis. That's enough for us to know right now. We don't need to know, immediately a lot of details. This can really force people to shut down. It can also re-traumatize people. So it doesn't mean that we don't want to listen, but we should not be bombarding people with questions about details. And using platitudes like, well, it could be worse, or, this too shall pass, or what I had said before, well, you're having a normal response to an abnormal event. Let's eliminate all of that and just provide, the reassurance, the information, and the connection that people need. And I did One of the handouts is on critical incidents. This is something that I have found to be really helpful. So you'll see, so this is what it looks like. This was sent to you in the email with the meeting link. But it says something here that, you know, stress reaction may last a few days, a few weeks, or a few months. By the way, and we can expect people to have a stress reaction for probably at least 4 to 6 weeks following a, you know, some kind of crisis. It doesn't, that's just part of what that natural recovery is. If it persists beyond that, then we want to think about post-traumatic stress disorder. But, you know, a few days, a few weeks, you know, 4 to 6 weeks, you know, that's perfectly understandable. And then this is what I like about this, is that signs and signals of a stress reaction, where it breaks it down into physical kinds of things like chills and thirst and nausea and chest pain. And then cognitive, right? So being confused, having nightmares, hypervigilance, which means really being highly anxious, um, you know, blaming other people, not being able to make decisions or solve problems, right? So cognitive kinds of things. And then emotional, fear, guilt, grief, panic, depression, anger. And then behaviors, right? Um, withdrawing from people, pacing, you know, not being able to eat or eating too much, you know, drinking more than normally, or if somebody has been sober for a while, might return to some kind of substance use, right? So this is what I like about this. I think it can be really helpful, not only to us as providers to know that there are, you know, different aspects of a stress reaction, and somebody could have more physical reactions and less of these other things, or somebody could have more emotional reactions and less of these other things. You know, every person is individual, and each situation can be different as well. So one example for myself is I was in a car accident a few years ago, and I had more of these physical reactions than these other kinds of things. At some point, I realized that I was probably going into to shock. Um, but then years ago, at a treatment program I was working in, we had a critical incident, um, and I had more of these cognitive and emotional kinds of responses than I did the physical or behavioral. So you know, each person is an individual, and each situation is different as well. So this can be part of the education piece for yourself, not only for your own understanding, but also, you know, giving information to the people that you're providing supports to. Um, I have found this over and over again to be very to be helpful. Some of the traumatic stress symptoms that come from hmm, the DSM-5. This is not um, to make any kind of diagnosis or anything, but I do have the comment here that if these symptoms are persistent or they get worse, you know, after 4 weeks, um, you know, 4 weeks or longer, then, you know, that's when we might want to think about mental health evaluation. And there are these kinds of things, right? So similar to what was on the critical incident sheet, but, you know, having nightmares, you know, just in these intrusive memories, you know, distressing recollections, you know, thinking about it, you know, and it's very distressing, you know, feeling like the trauma keeps happening over and over again. Even if it's not, I mean, that's what the difference here is, that trauma could be ongoing and continuing to happen, but even when it's not, feeling like it is. When somebody is triggered, so this psychological distress, the anger, the irritability, those kinds of things, or the physical reaction, so the things that were on the sheet, like the chills and nausea and chest pain and those kinds of things. So when somebody is reminded or triggered as a result of trauma. And then avoidance, right? So avoiding people, places, or things, anything to do with the crisis event, the traumatic event, people will avoid. And the change in cognition and mood, so persistent fear, horror, anger, guilt, and shame. And I bring this up because in the DSM-4, it was fear, horror, and helplessness. This has been expanded to include anger, guilt, and shame, which I think is a really important piece, especially about the anger, because often when people are angry, and particularly men of color, if they're angry, they're either A, incarcerated, or B, or both, sent to anger management. And there isn't any assessment of what may have happened to somebody. And the persistent negative beliefs, one of the things that we see as a result of complex trauma is a belief system that includes the world is not safe, you can't trust people, and good things don't happen to me. The DSM-5 calls them negative beliefs. I call them beliefs that make sense in the context of somebody's life and experiences. Why would you trust somebody? Why would you think the world is safe? Why would you think good things would happen to you if they never have? So the DSM-5 says they're negative beliefs. I just think that they're beliefs that come out of that complex trauma. And then there's also some symptoms of depression, right? Not feeling connected to other people, not having interest in usual activities, not able to experience positive emotions. And then the arousal thing, so not being able to sleep, maybe being self-destructive, anger, irritability, concentration, super anxious, this hypervigilance, jumpy, exaggerated startle response. So these are things that show up as post-traumatic stress disorder, but I'm putting them out there as just traumatic stress symptoms, just things that we would expect to have people experience as a result of crisis or trauma. So coming back to what I really some differences here. So I started out talking about being trauma uninformed, trauma informed, and trauma informed and culturally responsive. And so what does all of this mean in terms of practice? One is being trauma informed is knowing, right, that we know something, but knowing something is not enough. We want to do something with it. Right? So our services change, our approach changes, our understanding changes. Maybe we have more empathy and understanding towards clients, right? But we do something with it. And then there's trauma-specific services, like providing things like EMDR or trauma-focused CBT or seeking safety or TREM, beyond trauma, right? These are trauma-specific services. Most of us are going to be doing these two things, right? Being trauma informed and remember culturally responsive, and then trauma responsive, that we're going to do something. So we've attended a training, you have a few handouts. Whether or not this training has been impactful and I won't know if it's been impactful. But if you change something, if you've had a little piece of information that has been helpful to you and has increased your ability to provide effective services, that's when we know that we're trauma responsive. So I've talked a lot about being trauma informed and trauma responsive throughout this morning, and I want to give you 5 principles that are key to really being trauma informed and trauma responsive. And they are this: safety, trustworthiness, choice, collaboration, and empowerment. So, do clients feel safe with us physically and emotionally? And not just with us, but in our agencies. Are we trustworthy? Do we tell people ahead of time what we're going to do, why we're going to do it? And if we make a promise, do we follow through? Do we offer choice to clients on what they can do? Not what they can do, what we can offer and what they would like for us to do. So choice, collaboration, always collaborating with clients. There's a phrase that comes out of not the mental health movement, but actually advocacy and peer support, which is nothing about us without us, right? So collaboration. And then empowering people, right? Are we returning power? Because when you think about trauma, when you think about crisis, it's the opposite of all of these things, that people don't feel safe, they can't count on other people, there's no choice in what's happened to them. Certainly no collaboration, and they're powerless. So safety, trustworthiness, choice, collaboration, and empowerment, those are the trauma-informed principles. And the last handout that I gave you is the continuum of response, which just outlines all of this. So it looks like this. It has a column for psychological first aid, and it has a column for stabilization, which I went over a lot of this, and some of you already do, which is providing information and education to clients, teaching them some grounding skills. Of course, we always do safety planning. And so really these first 2 columns are an important part of helping people move towards recovery. And then trauma-informed care is what really covers everything, right? So safety, trustworthiness, choice, collaboration, and empowerment. So we are at the end of our time together. So thank you again. I appreciate this. And if anybody ever has any questions, feel free to email me. My email's on the first slide.